I'm Tina Woods. I've been here throughout the couple of days. I think this today has been really fascinating in terms of hearing about the latest thinking in brain research, mental health. We've talked a lot about preventative health. And in fact, the last two sessions were all around living longer and healthier, so healthy longevity. So lots of themes which actually looked outside sort of, I guess, the classic kind of description of healthcare. It was very much around everything around the social determinants of health. And now, of course, in our final session, we're really looking at health for the whole world, which is the title of the session, and the democratization of health enabled by technology. So that's really the thrust of the last session. So really delighted to have an incredible panel. Now, Sarah Baxter will be moderating the panel. She's from, formerly Google X, from X. She's the Director of Global Public Policy. So she'll actually be moderating the panel, and we'll do the sort of more in-depth kind of introductions to our panel, who you can see on the slide. But, the names that you will no doubt recognize, very well-known figures. And really, really pleased to introduce Joe Cerrell, who's here today, who's been living in London apparently for 10 years. He is the Managing Director of Global Policy and Advocacy at the Gates Foundation. I do not need to tell you what the Gates Foundation is, I know. Everyone knows what the Gates Foundation is, but no doubt we will find out more about the latest projects that Joe will take us through. Focus is and Joe's role, I know, focuses very much on government and partnerships. So Joe will take us through sort of 20 minutes or so, and then we'll hand over to Sarah, and then the session ends at 6. But we will have questions that you can ask speakers at the end of that session if you'd like to hang around. So I will hand over to Joe, and big welcome to Joe.
Welcome, everyone. Good afternoon. It's great to be here. Looking at the signage back here, I feel like Gates Foundation needs to add an X to it. It's like Gates X. So I'm the Managing Director of Gates X today, if you'll allow me. Again, really, really pleased to be here, and I appreciate the warm introduction. Joe Cerrell, again, I'm the Managing Director of the Foundation's global policy and advocacy work. And a note on that, when I started the Gates Foundation about 18 years ago, so a long time now, it's, our job was really to try to find the best and brightest, to provide some of the grant resources that we could to organizations that were doing good work, help scale up some of that, hopefully that would result in those organizations having a bit wider of an impact that they were doing on their own. And then all of a sudden we started realizing that even with the amount of resources that the Gates Foundation, then you fast forward to 2006, which those resources then started to include Warren Buffett's. Even those resources, as large as they were, as generous as they were really small compared to the kinds of issues that we were working on. So we really got into this notion that we had to get more engaged in public policy and advocacy. And so I help lead a team based here in London that works with governments closely in partnership to try to make the case for why issues like global health, agriculture are still worthwhile of government support, even while there's a lot of debate going on about whether it's in fact something the government should still be doing. Nationalism is on the rise, multilateralism a tough time right now, so we're really trying to make that case. And after all, it's really governments that are spending a vast bulk of the resources that are directed at the world's poorest. So we look at, in addition to the $150 billion, I think it is now, in overseas aid, that portion, $38 billion, I think is the most recent number that's really targeted at global health. So that's a bit on my background and the role of the Gates Foundation's London office. Today I wanted to talk to you a little bit about what we call Bill and Melinda's big bet that they've given to us and that they've issued to the rest of the world. A few years ago, they suggested, let's see if this is working, yep, that the lives of people in poor countries will improve faster in the years 2015 to 2030 than in any other time in history. Now, it's really an amazing statement when they first put this out there and asked that we really, think about what that could mean. The world will get better, and the lives of people in poor countries will improve faster in the years 2015 to 2030 than at any time in history. 15 years versus millennia, faster than ever. Over the last 25 years alone, we've seen some extraordinary progress. So it's given us hope to think about, how much more could be possible. But it still was quite a prediction. Some of the progress that we track closely and that the world should look at and take some pride in terms of thinking about the gains that have been had. We oftentimes think of the world as really a tough place right now, and it's hard to sometimes see a lot of the progress. But in the last 25 years, we've seen fewer people than ever contracting infectious diseases, fewer women dying in childbirth, fewer children dying before their 5th birthday. So for Bill and Melinda to win their bet, there must be some remarkable progress in a very short space of time. What is it then that makes them so confident? There's no doubt that we can do a better job of getting people the life-saving drugs and vaccines that we already have. But the truth is that simply doing more of the same, or even doing it a bit better, isn't going to get us anywhere near where we want to go. Progress on the scale of Bill and Melinda's prediction will only come through alternative approaches, original ideas, scientific discoveries, and technological advances. In a nutshell, the tools and things that we have available today to improve the lives of people are fantastic, but they're not enough to really accelerate the gains that we really want to see towards the achievement of the Sustainable Development Goal number 3, and to make true Bill and Melinda's big bet. And it's because audacious goals demand audacious solutions. The reason that Bill and Melinda are so confident is that they, like me, see the incredible innovation that is going on in health and healthcare right now. My colleagues on the panel here are experts who will give you great insights into some of the incredible breakthroughs that we're seeing, and I'm looking forward to hearing from them shortly about some of those. But before then, I wanted to share you 3 examples of how the Foundation is harnessing the ingenuity of the tech sector to build on this progress in global health through better delivery, better diagnostics, and better data. First is on delivery. And here, some of you may have seen this. It's just a remarkable example, something that we're extraordinarily proud to be supportive of. Drones are carrying medical supplies to hospitals and health centers in Rwanda and other countries from around the world. As you can imagine, one of the biggest challenges when it comes to getting medicines, vaccines, blood contraceptives to remote rural outposts is the state of infrastructure. So Zipline is a company which uses electronic autonomous aircraft to do it. And the very best things are that 1, they do it on demand, and 2, they do it at national scale. Here's how it works. I think this will play automatically. Yes. Zipline has a distribution center about 20 kilometers outside Kigali, the capital city. When there's an emergency, a doctor or a nurse at that hospital sends a WhatsApp telling the distribution center what they need. It's packed into a box and loaded onto a zip. Once the zip is ready to go, it's catapulted from 0 to 100 kilometers an hour in about half a second. It's monitored from a distribution center when the zip arrives at the hospital. It descends about 30 feet and drops the package using a parachute, which you've just seen here. It then returns to base where it's caught by a wire, like on an aircraft carrier, which you see here. Pretty cool. Zipline's founder and CEO, Keller Renato, tells a story about a 24-year-old mother who suffered complications after giving a C-section. She was given a blood transfusion from stocks held at the hospital, but more was needed. The mother's life was in grave danger, but the doctors called Zipline's distribution center and placed several emergency orders. In fact, they placed orders for more blood than you have in your entire body. All of it was delivered within minutes and transfused into the new mother. Doctors were able to stabilize her, and today we can happily say that she's living very healthy. Zipline provides this advanced technology which saves lives even in the most basic of settings. It's why our foundation is invested in this development and expansion, and why we're so excited by its potential. Now, the second example that I wanted to spotlight is a diagnostic, specifically an ultrasound scanner that fits into your pocket and plugs into a smartphone. And actually, thanks to my team here today, I brought one here with me. Ultrasound has, of course, been around for about 40 years. Most of us with children will be familiar with it as a way of seeing babies in the womb. The good news is that it's a proven medical technology with thousands of applications throughout all stages of life. The problem, though, is, especially when it comes to the developing world, is that conventional ultrasound is inherently expensive and inaccessible. Cumbersome systems and machines typically wheeled from room to room on a cart cost upwards of $40,000. I remember with my wife, when our first and then second and third child in that hospital room, that wheeled cart with a big Philips or GE, I forget which piece of technology that was wheeled around, and it was a reminder then it's not necessarily a practical application for a lot of parts in the world, but that's changed with this new intervention. This firm Butterfly Network has created the world's first handheld whole body ultrasound system called the Butterfly IQ, which costs less than 1,700 pounds. And here it is. I brought a little video to show it to you in action. This device has paved the way for early detection and remote diagnosis of health issues anywhere in the world, something our foundation is supporting, with an investment to accelerate the development of an Android app and to write software intended to guide untrained users as they scan. An article recently in the New York Times highlighted Butterfly's effectiveness. They talked about a report of a 6-year-old boy named Gordon who lives in a remote part of Uganda. Gordon was struggling with a persistent cough and swollen lymph nodes. He was tired, he was unwell. The nearest ultrasound machine was many hours away from his home. But using Butterfly IQ, a doctor and clinical officer watched Gordon's lung expand and contract on an iPhone linked to a scanner. The image suggested his lungs had fluid in them, so Gordon was prescribed an antibiotic, and blood tests were ordered to rule out tuberculosis, malaria, and HIV. The scan was then uploaded so that an ultrasound specialist 7,000 miles away in Toronto could double-check the diagnosis, which came back early-stage pneumonia. And for Gordon, the prompt diagnosis meant that 24 hours after he started his antibiotics, he was sitting up in bed, smiling and feeling much better. Now, many of you know that pneumonia is the single biggest killer of children in poor countries and frequently misdiagnosed. Thanks to Butterfly IQ, Gordon didn't become another statistic. The third example has to do with data, an exciting potential of AI to revolutionize the effort to eradicate malaria. Thanks to multinational organizations like the Global Fund and bilateral programs from the US and UK, the number of deaths from malaria have fallen by half, and the case count has dropped by 60% since the year 2000. Still, there were 219 million malaria cases worldwide and 435 deaths from the disease in 2017. In fact, 2017 is one of the first years where we've started to see a slight increase in the number of malaria cases, which should cause alarm to people who've been working on this issue for so long. And malaria is usually one of the statistics we cite that really indicates a lot of the progress that we've been seeing in global health over the last 10 to 20 years. One critical tactic for getting these numbers down farther and faster is to pinpoint exactly where malaria is spreading in order to stop it in its tracks. The trouble is that when it comes to public health, most maps are not what you would describe as dynamic. Typically, they're based on information collected months or years before and somewhat unreliable in the information that they provide. And if you can't track what's happening where, then it's much harder to know how to respond. The promise of AI is that it opens the possibility to gather and interpret the data in real time. That, in turn, means the treatments and preventative measures such as mosquito control and bed nets, can get better targeted. So we've teamed with Google, the Clinton Health Access Initiative, and the academic and public health partners to harness machine learning to improve decision-making and save lives. The project is called DISARM, or the Disease Surveillance and Risk Monitoring. It's building an open-source platform comprised of a web-based application and a set of customized algorithms accessible through an application programming interface, or API. Pilots are now being staged in Zimbabwe using the Google Earth engine to map malaria. What happens is that every time someone is diagnosed with malaria in these countries where it's operating, the team goes to the village where the infection has occurred and collects GPS point with a precise location. DISARM's algorithm takes this data and combines it with information on climate, ecology, and infrastructure from other sources to predict transmission risk for other villages not included in the original data gathering. This more complete picture allows programs to target their limited resources to the right people in the right place at the right time. Malaria is one of the most deadly and devastating diseases in human history, and ultimately AI can accelerate the path to elimination. Because as you know, when it comes to decision making, information trumps intuition every time. Now, each of these examples is critical to our foundation's vision of a healthcare ecosystem where hardware, software, and data come together. And they each have something in common that I think is important to keep in mind for today's conversation. Their roots are in rich world use. They either started off as something for developed world markets, or they've adapted technologies that were developed by and for those markets. It's also worth considering that both Zipline and Butterfly IQ are commercial ventures. This isn't philanthropy we're talking about. I'm not making a pitch for donations. In fact, our foundation's chief executive, Sue Desmond-Hellman, tells biotech and pharma companies all the time she doesn't want to talk about CSR. She wants to talk about P&L. There is a market out there for your inventions and your innovations. And thanks to the convergence of tech and healthcare, your world and my world is closer than ever before. Today, engineers and computer scientists can save lives just as doctors and nurses do. So ask yourselves, could what I'm working on have an application in global health? Could it help to win this big bet that's put forward by Bill and Melinda? And if the answer is yes, the Gates Foundation stands by and ready to help. Just as you've seen, we're already working with entrepreneurs and companies to bring some of the most promising solutions to life, and we're doing it with some really innovative forms of finance, which I hope we'll get into a discussion about. Not only will such partnerships bring our two worlds together, far more importantly, they will start to bring the developed and developing worlds closer together. And the good news for you is that entrepreneurs and companies won't just drive progress, they'll benefit from it. Thanks very much.
That's great, thank you. Fascinating. I can't wait to ask questions. My name's Sarah Hunter. I'm the Director of Public Policy at X, formerly Google X. And actually, it's great to hear the big bet concept being talked about here. We believe in big bets a lot at X, and I'm thrilled that we've got a great panel who are also all taking big bets. So I'm going to invite up onto the stage our three panelists. I want to invite Dr. Precious of Baobab Circle. I think I pronounced that right. Dr. Waheed Arian of Arian Teleheal, and Dr. Ali Parsa of Babylon. So I have read a lot about everyone's company here, and I'm not going to try and summarize it on behalf of them. I'm just going to start by asking each of you to tell us, in your own words, about your company or your organization and your origin story. Tell me why you've created the business you've created. Maybe... Absolutely.
Much more interesting story than...
Oh, really? Let's start with Precious. Dr.
Okay. So I'm Zimbabwean. I'm a neuroscientist and an epidemiologist. And how I started Baobab is I was working in the field of HIV and an infectious diseases epidemiologist. So really excited about outbreaks. So be it an Ebola outbreak, whatever, would be there to deal with it. And as Joe mentioned earlier, we're now actually starting to tackle infectious diseases. So hope is in the horizon, and the Gates Foundation has contributed significantly to this. But what I noticed as well, working on the ground, is that the same people that we're actually managing to save from malaria and other infectious diseases were then now being struck by strokes. So if you look in sort of the hospitals now, people are not really dying of HIV, but they're disabled by strokes, they're blind, etc. And that's because actually there's been this shift in demographic, because as people have become a bit wealthier, actually what's happening is that the non-communicable diseases, diabetes, hypertension, are actually becoming a problem. And why this is a concern is, if you look across the African continent, 1 in 3 adult Africans suffers from high blood pressure. That's a huge amount. And that puts you at a high risk of all sorts of awful conditions. But the impact from a development perspective as well is that these are the most productive people. These are parents of children. So if they can't work, they're out of work, the kids can't go to school because there's no money. Anyway, so this is how it started, was, okay, so there's this problem, but at the moment no one is really paying attention because it's not really an attractive problem as such. It's not an infectious disease. And actually what's particularly really dangerous about this condition is that it's not just the tablet, it's what you do as a person. So 90% of your outcome is what you do. So you have to really engage the person who has that health condition. And our health systems just can't cope. I mean, they're just overloaded already. So that's why we then developed Baobab Circle and an app. It's a platform called AfiaPap for people with smartphones. We have a smartphone version, which is an app, and also for basic phones, because in the context where we work, not everyone has a smartphone. And the idea behind is that we actually coach the person and we personalize it, so we get to know you. So we use algorithms that actually get to know you as a person, and then we start to collect data not just on the condition but also other measures, be it blood glucose, be it blood pressure, be it weight, all the different parameters and where you live. And with that we can start to actually follow you and identify. The idea is to identify before you have a really horrible catastrophic health emergency, so that we can intervene before. Where we are now, we have I think at least in Kenya, at least we have about 15,000, but we're also in Zimbabwe, we're in Kenya, we're in Tanzania of users. So we built it from the ground up because we wanted to know what do people need in those contexts. So we built it with our users in mind, and what we're finding is that we're starting to see, it's still, so our oldest ones, we've been following them for about 2 years now, and actually we're starting to see fewer I suppose, sort of health emergencies from them. And the idea is that, you can start to actually change not just people's behavior, but their outcomes by actually providing them with a service in their own language, in a content that's really relevant and built for the settings.
Thank you. Dr. Arian, tell us about yours.
Thank you very much for having me. My name is Waheed Arian. I'm an emergency medicine doctor in the UK. The organisation or the charity that I lead is called Arian Teleheal. Through this organisation we have volunteer specialists from NHS, from the US, Australia and many other countries across the globe, and they give advice, specialist advice on smartphones to medics in conflict zones and in low resource settings. That's in simplest format what we do. The medium we use is actually secure social media. So that's the other extreme of machine learning, but you've noticed from Joe Cerrell's presentation, a brilliant presentation, that WhatsApp is used even in the zip line. So that shows that using simplest formats or platforms of media are very, very crucial in low resource settings. We started first in Afghanistan, and I'll tell you a little bit story why we did and went there, start over there. We then went on to Aleppo in Syria. Now we operate also in Yemen, and through partnerships, strategic partnerships, we're helping in South Sudan, South Africa, and we're hoping to go to other countries in Africa through a partnership with the Welsh government. And the story behind it is that I think it's important that when we talk about technology, when we talk about the vision, we shouldn't forget why we do it in the first place. I think, well, again, the important topic that you mentioned is the bets. Bill and Melinda Gates bets. So I had a similar bet. I was born in Afghanistan in a war-torn country. Spent 15 years in war, and that's when I was inspired in the first place to become a doctor. Of course, with lack of education, I did about 4 years of schooling back in Afghanistan and spent 3 years in a refugee camp suffering from tuberculosis and malaria myself. So through that interaction with healthcare professionals, I became inspired to become a doctor. But more importantly, it was in me since that young age to be able to give something back. I didn't know how and when. And then when I came as a refugee at 15 years old to the UK, I started working, studying and so on. Finally, I managed to become a doctor, graduating from Cambridge University, Harvard and Imperial in 2010. Then when I wanted to give back on my own, I tried to recruit other doctors to come with me. And they were telling me, Waheed, are you crazy taking us to Afghanistan or Syria? Nobody would come with me. So for 4 years I tried that route of using physical presence in conflict zones. I didn't succeed until I came across the concept of telemedicine, which was there at the time, used by MSF and other organizations. But on the ground, it required, the store forward method, that you have machines over there, machines over there. In conflict zone, they didn't work out. And then I noticed that everybody was using a smartphone. Even a child, they were using quite cheap smartphones, were better than my own phone coming from the UK. And I thought that they were all realized they were all on social media. Not so secure at the time, for example, Skype, but later on they became encrypted. And that was the light bulb moment for me to say we can do that. And that was the story behind it. And I'll talk about the partnerships and how it developed, hopefully, after Dr. Parsa.
Dr. Parsa?
So, my name is Ali Parsa. Babylon, I built a chain of hospitals. I got lucky, did very well. We had thousands of employees, hundreds of millions of revenue, so on and so forth. And one of the things you understand when you run hospitals very quickly is that the vast majority of people's healthcare needs have very little to do with hospitals. Once every 20 years, you have an episode, you go there. And for almost everything else, we kind of do it not so well. And we sat back and said, can we do with healthcare what Google did with information? Can we make it accessible, affordable, put it in the hands of every human being on earth? And if you I'm an engineer by my background, and if you kind of sit there and do what every engineer or mathematician does, which is dissect the problem to its smallest elements and say, how do I solve this? If you think about accessibility, as long as I can deliver most of the healthcare most people need on devices they already have, that's highly accessible. We do that. My amazing, amazing colleague there, Shivam, delivers 3,000 consultations a day, every single day, in Rwanda, to some of the most left behind people in the world, right? On their mobile phone, and these are not smartphones, these are feature phones, right? The question is, there is no accessibility without affordability. And when you look at the costs in healthcare, they fundamentally sit in two buckets. They sit in salaries. Doctors, nurses in every society are amongst the highest paid, and they sit in timing. Most diseases, by the time they show their symptom, a $10 problem has become a $100 solution. So all we do in Babylon is to create technologies and solutions that allow us to deliver services at significantly lower cost by managing our doctors and our nurses and getting patients to come to them when they need them. Doing that very simple thing, for instance, in UK today, in London, we deliver primary care. For decades, you wait a week to get your doctor, maybe, and you have to, it takes time, right? And then when you see a doctor, there's a waiting time and so on and so forth. Now what we can do is we can, and it's, within 24 hours a day, 7 days a week, for exactly the same money that NHS pays any other GP, we can deliver services and do so without any waiting. It's less than a few minutes or an hour or so. And so where does that come from? It comes from the savings the technology does. We've done that in Rwanda, we've done that in UK. I'm a refugee too.
Yes.
And the two of us actually have come from the same parts of the world. I'm from Iran, you're from Afghanistan. These borders are rather artificial. You go back a few hundred years, there is no such thing, right? And and I tell you, and I finish with that, I was a native and I was an immigrant. I was incredibly poor, and now I'm as rich as I want to ever be. I was an outsider, and then I became an insider. And the truth of the matter is, it doesn't matter where I was or who I was. What I saw is that every human being in the world, irrespective of their class, their society, their nationality, have exactly the same desires. They just have different opportunities. And it's upon us to bring that exact same opportunity to everyone. So in Rwanda today, a human being can see a doctor within minutes. Better than anybody who can do in Britain, unless you're a member of that. And that's just a reality, right? It can be done, and people everywhere need the same thing, and it's us, we, who do it. Thanks to people like you who pay for it.
I think Joe's going to be asked to write some checks. Well, actually, that was going to be my question. It's so interesting hearing the three of you talk, because you talk like entrepreneurs. You're all doctors, but you also are entrepreneurs. And coming from the UK, where my expectations of healthcare are from a public service, but it's a very different sort of tone of voice and insights that I think you bring as entrepreneurs. From a sort of funding perspective, how is it different? How does the technology change where you get your money from? I mean, Joe, I think of the Gates Foundation as a philanthropic organisation, but you've been talking about private sector funding as well. Just talk to me about how you've changed your perspective on funding healthcare innovation through technology.
Yeah, and I think it's changing rapidly. And I'd say that initially our journey into trying to understand how innovation is funded really led us to understand a little bit more under organizations like the National Institutes of Health or other big funders from a government perspective. But government is huge, and the NIH at $30 billion a year is one of the bigger of those entities. But clearly innovation is happening everywhere, and innovation within the private sector obviously is a huge, now tapped, but still a resource that should be tapped to greater potential. I think for us, of the three innovations I described, two are funded through normal grant mechanisms. Butterfly IQ is funded through an investment fund that we've started as part of the foundation, but is managed somewhat separately through what's called the Strategic Investment Fund. And it's a $2 billion set aside that's been used to make more traditional investments, equity, debt, to try to enable companies that have promising technologies but don't necessarily have the market certainty when they think about their products being used in poorer countries, nor do they have the marketing or the know-how on how to distribute those products. What we can do is come in and make those kinds of investments and say, how could you expand these applications to diseases, conditions, some of which you've heard just here, to make it available to people more widely around the world. And so I think it's another form of finance that we're starting to see, and what we're also encouraging others who are interested in funding health to consider. That is, governments will still be incredibly important at big innovations, but if we can tap private sector innovation and provide some of that risk capital or patient capital via philanthropic monies, then I think we will have a chance to really unlock a lot of new innovation in the future.
Yeah, and presumably, any of you, the different markets you work in require different funding mechanisms. Dr. Lunga, you work across many countries in Africa. Do you find different sources of money to subsidise what you're doing? Is there anyone paying for what you're doing from a sort of citizen perspective?
Yeah, so actually we have partnerships with health insurance companies and telcos, and so that's what's been our funding model. And why you mentioned that we're businesses, and I started off as a public health professional on the ground, and really it's really about how do you provide a service for the people, and it was doing that work that I realized that actually it's it's a huge problem. No one player can actually make it work. You need multiple players, just as in energy provisions you have private and public sector. The same is needed for health, even in emerging economies, even in low-income countries.
Actually, and that brings me to another thing which I've heard all of you talk about, is partnerships. There seems to be a lot of reference to the need for multi-sectoral partnerships to make your missions work. Do you tell me about your vision of partnerships, Dr. Arian?
So I'll touch briefly upon the business model that we have. We started off in 2014, piloted the scheme in 2015 with 5 hospitals. We were successful to scale up pretty quickly because of the simplicity that we were using, and the fact that we came in with a passion that was seen on the ground in conflict zones. So the secret sauce that we have is actually partnerships on the ground in conflict zones and in low resource settings, that I directly go there myself and network with the heads of state or the ministers. It's not an easy thing, it's quite risky, but I'm very passionate about that. So we actually didn't think about the business model in the beginning, but we got to a stage, we've got a global traction that many countries in low resource settings said, can we benefit from the specialist care that you provide? We have about more than 100 kind volunteer specialists, but that's not enough. So that's where the limit is. So in terms of service provision, that we're at a limit, but now we work through partnerships that we would like to give the template to other organizations on the ground. We strategically work with them. For example, I'm here today, one reason for that is being a goalkeeper for the Gates Foundation 2030 vision. And that's very kind of them. And also that we partner with Health Education England in areas like in South Sudan, in Africa. We've started direct interaction and partnership with WHO, especially in the Digital Health Advisory Group, that we've kind of worked a lot on the governance around the digital health, that I've spent months and months myself working with international lawyers to figure out how this works. And Dr. Pass is a specialist in that. It knows the data and the governance is the trickiest part, actually. The technology itself and the provision of service and so on, that's the easiest. It's how we kind of like make sure that we protect the organization, we protect the service providers and so on from litigations, whether it's clinical, legal and so on, that we partner with organizations around that. And finally, I'm the UN Global TV Ambassador for the United Nations, so that allows me to use several badges in different places. And in the process, I've become a politician myself. But I have to do all that and using the media as well to create exposure and to create traction. Moving forward, so we need funds. So we'll be getting in touch very soon. But it's actually working in partnership how we can work towards a similar vision. I think this is something that's probably for budding entrepreneurs here. Dr. Pass is again a specialist in that, in fundraising. He can tell me how to become rich as well, hopefully one day. But the idea is, whether it's for-profit or not-for-profit, the partnership is all going towards the same vision. If it's not working towards the same vision, it will not work. So identifying the mutual grounds, whether it's the giving body, whether it's a specialist, whether it's advisory group or anybody, just working out what you can do for them, and that's what I do always, and what they can do, you know. And then, of course, the governance is important. You know, what are the structures in place? We're a registered charity, and we can create a company similarly as well, but we have to be very careful. We do not mix things and so on to make sure we are accountable. So that's another aspect to partnership as well as accountability. It went on long, but I think it's we have to touch on all of that. Yes.
Okay, so Dr. Parser, as a company, Babylon works here in the UK, but you work in Rwanda, and you work within the sort of traditional healthcare systems as an entrepreneur. Like, talk to us about how you do those partnerships, and any tips for anyone here who's trying to crack the nut of working within the traditional healthcare.
So, I think it's a really important one. There are not that many technology companies in the world. If you take Uber out and a small number of others, maybe you could argue Amazon, but who actually have got their hand dirty to put technology in the real world. You know, if you're at Google, you're writing algorithms that just kind of go everywhere, right? But you don't have to be in physical world, right? So, Facebook. It's a very different layer of complexity when you mix bits with atoms, right? And that is, and anybody who is so arrogant to think that you could do that on your own is in crowd cuckoo, because that's just not possible, right? When you are mixing the reality of what happens on the ground with what you think, you just need people who are on the ground, right? So everywhere we partner. So in China, things that are public, we partner with people who are brilliant in China, with Tencent, WeChat, right? So now imagine the effect of that. We know how to do artificial intelligence and the delivery of healthcare. They know how to reach 1 billion people every day. And imagine the effect of these two together. If you can put an AI doctor that tells every Chinese person when they have a problem how they fix it, how much more powerful is that than me going in there and saying, no, I want to do this now on my own. So I think a bit of humbleness goes a long way in the world. And because I'm so short and small, I just kind of learned that you have to bend, not to break. By the way, you said rich. I didn't say I was rich. I said I got all the things I need. That's a fundamentally different thing.
I'm still searching for that.
I agree with you. And actually, we have a drone project at X as well. And actually, you know, it would be lovely to be able to just fly drones anywhere. But we all know that actually you have to get permission from aviation authorities. It's very complex. But I often think that when you're a technology entrepreneur, the frustration is the slowness of getting the partnership and the permission. Like, it can be very frustrating particularly when you have human lives that you think you can be saving. Joe, any vision on how that sort of at that sort of Gates level, how that's progressing and changing? I mean, do you think that governments and those sort of global regulators get the need to sort of move with the technology speed, or do you feel that that's sort of still a bit of a work in progress?
Yeah, of course it's a work in progress. Absolutely. One of the things that we noticed, I say we, Bill and Melinda noticed early on when they were when they embarked on this vision of trying to close the gap in inequity between rich world, poor world countries, was the fact that on average it took 15 to 20 years between when a rich country would have a drug license approved and available to the same drug being approved in many poor countries. And it's oftentimes because the regulatory environment, if you think about it, very fractured, 54 countries in Africa, many on a different regulatory regime. So there were just some fundamental fixes, still not fixed, but just some fundamental things that could really close the gap. If you think about the WHO, which has responsibility to pre-qualify drugs and diagnostics as amongst their other, the WHO has really been underfunded for a long time. So the speed at which they're able to process these dossiers and very complex types of approval processes. I mean, it is, I think, something that we do need to figure out how to do. Now, I think there's been, again, a lot of improvements in that, but we have a long way to go in terms of, and that's the inequity that we really try to figure out, which is how do you close the gap between when things, life-saving interventions, are made available in richer countries and the time when they're available in poorer country settings.
Okay, so I want to switch gears a little and talk a little bit about ethics. We've talked, I don't know if everyone's been here for the last 2 days, but there's been a lot of talk about ethics and tech at the other stages. And of course, in healthcare, ethics has always been a big part of the thinking. I'm curious to know, how does the use of AI and new technology change your thinking about ethics as health practitioners? What does it force you to do differently? And where are the big risks and opportunities there? Dr. Wilson?
So, am I allowed to be a little bit
Be honest. Honest controversy. I love a controversy on a panel. Come on. Can you not hear?
You can't. Oh, sorry. So, what is the? Look, it is absolutely clear that when you have responsibility with artificial intelligence, you have whatever algorithms you write or whatever you do gets distributed globally almost at the same time, right? So, and it affects many, many people, and you have to be incredibly super careful about it. No question about that. The data, the trust, that's got all of that, incredibly important. But I also think that we need to not look at this in isolation, but look at the reality of where the world is today. Where is the ethic that 50% of the world population has no access to healthcare? Where is the ethic that 5 billion people have no access to surgery at all? Where is the ethic that it takes 17 years for best practice to become common practice in medicine, right? So when you make these choices, you have to be super careful on making them in relative terms as well as in absolute terms. So every time you do not allow somebody to have access to your information because you're keeping it back, you're denying somebody the access to that information, as imperfect as it may be, right? And that's the balance you have to manage. So I genuinely think we're negotiating. Now, there is another thing that worries me, and that is when people start talking about ethics, you usually kind of start worrying a little bit, right? It's like people who say, I'm charitable, or I'm a really nice person, right? One of the reasons... Are
they hiding something?
Yeah, one of the reasons where the technology industry is talking about ethics is because, frankly, for a long time, it forgot about ethics, right? It took people's data and it sold it, and without their permission, right? And it infringed on people's day-to-day life. That's just a reality. But no punishment at Google, by the way. So that's the reality of what happened with technology, and therefore there is a backpedaling where people are now trying to make it up. But don't brush everybody on the same thing. I think that there is many, many brilliant ethical technology solutions out there, and they didn't all sell people's data or did things that deserves them losing trust.
Yeah.
Dr. Lunga?
I think
you said it all.
He said it perfectly. I agree, and particularly in health, because even giving a medication, you're always thinking something's going to do good, might not do good, but it's been woven in from the beginning that it's important to actually provide services, because it is unethical for somebody to die where they didn't have to die.
Doctor, I don't know.
I think you both clarified it very well. Can you hear me? I'm a bit paranoid now.
Yeah.
I'll just mention, I'll add on just a couple of points, and that's, in other words, Dr. Pastor mentioned relativity, which is extremely important, that you have to see where the data is being used and relative to what. I will use another term close to that, that is, contextual, or on the ground, where you actually collect the data from, in what context you gather it. We look at it, for example, here, when we collect the data, behind the machine, we can see where it's coming and so on. But where we collect it from, it really we have to have governance in place in every place, a separate set of governance. General set of governance, of course, why we're going to use it and so on. But not to kind of put people at disadvantage or kind of, it's unethical for me to use data from a poor country to use it somewhere else, unless it is going to help back the poor country. You've done that brilliantly with you helping Rwanda back, for example, with the AI platform that you've created and so on. But it would be unethical for me to collect data from Afghanistan, for example, Syria, and conflict zones, and then create a company with it and then sell it and so on. So it's really important. And then how we use that data, we should be able to create not kind of different technologies. I'm still going to stick with encrypted social media there, whereas I have data here, I can create machine learning for people who can pay for it. I think that's, again, something. I'm just trying to use examples here that we have to give the advantages of AI back equally from the places where the data has come. So when we think about data, we think it's just coming, for example, in the UK, or sort of an umbrella term for it. But no, the data is actually very contextualized. It's coming from various backgrounds, groups, and so on. And we have to really pay attention to that those people, they have to benefit.
Yeah.
And I think that's a big challenge, in my view.
And can I just quickly add something on the algorithms anyway, in terms of sort of building them? Because ultimately, when you build an algorithm, you're making assumptions, and those assumptions can change when your data changes. I think actually where maybe fundamentally ethics are important is that actually when we're building those algorithms, it's important to have an inclusive model of building. So that means including people who are really diverse, who are not the typical sort of people, but you need to really include them, because otherwise your algorithms that can be really smart may not really apply in some other situations because you didn't include those people when you're building them.
What about the data you use? Because it strikes me that it's only as good as the data you've got, and there's lots of examples where data sets that are not complete or not showing the full sort of breadth of the ethnography in the community actually come up with some very bad advice. Is there any role you think for third parties or governments to sort of set data standards, or where do you feel the sort of the leadership should come from to make sure the data sets are really good enough?
So if you think about the spectrum of AI, and you take about entirely human-curated teaching versus entirely machine-learned activity, that entirely machine-learned, deep learning and self-learning, if you want to call it, that is right now not possible in medicine. It's just not there. I mean, we try it. I know DeepMind guys have tried it. Because we just, unlike the game of chess or the game of Go, you don't have a set of rules that you could say, here is a rule, play against yourself, and you know whether you're... This is very complex. You can't write the set of rules in volumes of books, let alone in paragraphs. So we're somewhere in between, and we're bit by bit moving to the other side. And that curation creates the integrity of data. So we saw that with IBM Watson when they went and spent $2.5 billion buying a whole set of data sets, and it just didn't work out because actually, well, guess what? those data was put in by human beings and they were flawed. And the difference between what we saw with Microsoft when they unleashed their chatbot to the world, it took, 24 hours for it to become racist and misogynistic? Why? Because the world is racist, right? I mean, and it learned from that racist word. So I think you will always have that. I only challenge, it shouldn't be just go to governments. It's everybody's role. Because the moment you pass it on, then the responsibility is off your hand, right? You could say, oh, I did it wrong, but the government should have caught me. It's our job. Honestly, the governments, I have not met one, maybe Joe has, maybe you have, that is equipped to do this. They're just so far behind. It's just not there, right? They can react in many years later. It's our job, our responsibility, our word, and we can't pass that to anybody else.
So we've got 5 minutes left. So I want to finish with a quick fire round. I'd like to hear from all of you. Looking at the next 5 years ahead, so not long in medicine terms, what is the great opportunity that you're excited about with technology, and what's the great threat? And I'm going to start with Joe and give you time to think.
I talked about one of the 3 technologies that we're particularly excited about. Next 5 years, I think the eradication of polio will be one of the world's great achievements. And I mention it not as a technological feat, because it really is a human feat, and definitely a test in endurance and patience and persistent funding. But I also think that the science of eradication, the operational research that we'll get from trying to figure out how we can literally wipe out some of these big killers that have been around for thousands of years. It's a really exciting time to think about how we can tackle more deadly diseases, and I think it will pave the way for us to do just that in the next 5 to 10 years.
Let's do opportunities. Oh no, let's have a threat at the same time. Let's have what's the big threat? What are you most worried about in the next 5 years?
Whether the world.
Do you not worry?
No, we're worried about lots of things. I mean, I worry about the world's attention on health fading. I think that the world is looked at, and by almost every imaginable graph, we've seen signs of progress. Under 5 child mortality, rates of AIDS, TB, malaria going down, maternal mortality. I mean, we've made meaningful advances towards not only the MDGs, but now the global goals. I worry that the world's attention will start getting fractured to so many other areas that we'll think either we've done the job, we wish we could do that, and we'll start to see a comeback. So we're panicked by that. We think we need to kind of remake the case for why global health matters and why we need to continue to invest well into the future.
Good point. Dr. Lunga?
I think the ability to collect big data, actually, to collect data from the field is really promising. Now, why I say this is that a lot of sitting down with somebody from the south, many of the medicines or health policies that are then shipped globally have actually come from the US or Europe and are not always really appropriate. And I think now that we can start to actually collect that data and analyze that data, we'll start to actually be able to deliver context-specific medical interventions, which are really, really needed. And so that I see that as a way of optimism, because then that's when you really, truly democratize access to health, when it's not just copy and paste. So as a threat in the next 5 years. Well, I mean, we talk about, it's not technology, but it is climate change. And we talk about climate change as if it's something that's coming. Again, I'm from Zimbabwe. It's already there. You go to, Uganda, the Rwenzori Mountains, malaria is increasing there because actually it is warming up. So I see that it's actually going to get worse and people will be displaced because of that. And that does worry me because that's the context we live in.
Dr. Arian?
Thank you. Well, I think you've summarized it very well there. In terms of the opportunities in the next 5 years, in my view, moving away from data, I think in the first place from the countries that we can collect more data to create more contextualized machine learning in the future, the big opportunity is that we can go around and ask those countries or those regions, what are the opportunities for them, rather than us talking about the opportunities for them. And that requires hardcore networking on the ground to go from country to country, not making any assumptions. One is that we sit behind and think that, okay, this is how it should be done, but on the grounds their priorities are pretty different. And somebody who keeps moving around from city to city, even within a country, I find that the priorities are very different from one place to another. The discrepancy between healthcare provision or need, again, from within a few kilometers changes. So if we make that assumption that we're going to create something that will help everybody in the world, I think that's pretty naive. I think we really have to, it's really a lot of hard work to be done. We can't get, I know we can be optimistic, but we really have to put the hard work in there. And again, that's partnership. We can't do it on our own. We really have to be humble on that. We have to rely on people on the ground with experts in the field of AI, and also people in the field of diplomacy. You really can't do without networking or bringing in the policymakers. Even if you create something for a country, if they don't apply it, you failed, basically. So it's really complicated. I think that's where the threat is as well. From the outset, when we say health for the world, it looks very simplistic, optimistic, rosy. It's not. And sorry to give you that bad news, but it's really, again, the threat are so many interdependent factors that you have to analyze every country, every city, one by one, in order to be able to provide the healthcare for everybody. Yeah.
Yes, okay, so the short answer is the intersection of technology and biology. I think it's going to change everything beyond our understanding. And for those of you who just want to think about this, we all talk about AI, but frankly, I'm old enough to remember that we did AI 30 years ago, the maths of AI. What's changed is all the stuff you hear about, but what is about to change is much more. Quantum computing, 100 million-fold faster than ordinary computers. Think about this, 100 million-fold. 5G, 100 times faster than 4G. That's if I'm on a bicycle today, that is like the equivalent of sitting on a supersonic jet, right? The Internet of Everything, from 7 billion connected devices to 20 trillion connected devices, right? From predictive analytics to prescriptive analytics. Not what are you going to do, but when, how, which way, right? So when you add all of these things and you think about synthetic biology, the fact that we have worms that can live 6 times longer, rats that are twice as intelligent, tomatoes that don't age. These are things we do today, Tim. These are things we do today. Bring them together. The world, this is the last time, in my view, that humanity was evolved by if you call evolution. We now are on the threshold of doing it by design, right? So where is the threat is exactly here too. Where the opportunity is exactly where the threat is. So I'm incredibly optimistic for all the reasons I just said, but which way it goes, it's our responsibility. It's us as human beings, every one of us, who are the guardians of this incredible moment in history that no one before has lived, and for a long time, perhaps no one after us will have this effect of that change.
And that great summary, I'd like to thank our panel and see you.
Thank you. Well done. That's great.